In Chapter 32, we'll be discussing respiratory pharmacology as well as treatment of asthma and COPD. So, starting on slide 5. So respiratory diseases are any disease process that interferes with gas exchange in the lungs, changes the concentration of oxygen and carbon dioxide in the blood. Anytime we do that, we can cause shortness of breath if the patient isn't getting enough oxygen. So COPD, or chronic obstructive pulmonary disease, is caused by emphysema and chronic bronchitis. Both conditions are irreversible and lead to changes in the respiratory system. Chronic bronchitis is caused by the chronic irritation of the respiratory tract. Cigarette smoke and other environmental pollutants increase and thicken respiratory secretions of mucus, and chronic exposure to these pollutants causes degenerative changes in the respiratory lining and mucociliary escalator system, or that system that brings the mucus out. As mucus secretions thicken and accumulate, they can interfere with respiratory gas exchange. Symptoms of chronic bronchitis include a productive cough, difficulty breathing, increased respiratory infections, and restriction of physical activity. Emphysema is a disease process involving the destruction of alveoli or air sacs. Protease enzymes that cause destruction of the alveolar walls are increased by air pollution, tobacco, smoke, and other respiratory irritants. This causes enlargement of the airspace within the lungs and leads to hyperinflation. Individuals with emphysema usually have difficulty expelling air from the lungs. Treatment involves respiratory exercises designed to increase the efficiency of respiration, as well as oxygen therapy and administration of bronchodilators and anti-inflammatory agents. Asthma is a respiratory condition characterized by bronchoconstriction, shortness of breath, and wheezing, and there's usually triggers that are associated with it: allergens, air pollutants, cold air, infections, and exercise. So these factors stimulate the release of chemical mediators, again from mast cells and other cells involved in the inflammatory process, and that leads to bronchoconstriction and inflammation. So the chemical mediators, we've already discussed histamine. So during an inflammatory reaction, chemical mediators are formed and released from injured tissue, mast cells, and leukocytes in the respiratory tract. These mediators are responsible for most of the symptoms and complications of asthma. Wherever there is insult or injury to the body tissue, histamine is rapidly released from mast cells. In the respiratory tract, this causes bronchoconstriction, increased vascular permeability, and thus edema because fluids leak out, as well as infiltration of leukocytes, particularly eosinophils. Eosinophilic chemotactic factor A, or ECF-A, attracts eosinophils to the site of irritation, and it prolongs and worsens inflammation in the asthmatic process. Prostaglandins and leukotrienes, another type of chemical mediator, are both derived from arachidonic acid, and they are formed and released in inflammatory conditions just like asthma, and they cause bronchoconstriction, edema, and mucus production. Prostaglandins are also involved in a variety of other physiological functions in the body, as well as inflammation and the generation of pain. Leukotrienes are potent bronchoconstrictors with long durations of action and considered to be one of the more important chemical mediators of asthma. Okay. So the role of the autonomic nervous system. Bronchial or smooth muscle tone and secretion of mucus is normally influenced by the sympathetic and parasympathetic divisions of the autonomic nervous system. Sympathetic stimulation by epinephrine produces bronchodilation. Parasympathetic activation through the release of acetylcholine produces bronchoconstriction and increased secretion of mucus. So irritants of the respiratory tract stimulate vagal reflexes that result in parasympathetic activation. Sympathetic activation of beta-2 adrenergic receptors has been shown to increase the formation of an intracellular nucleotide known as cyclic adenosine monophosphate, or CAMP, cyclic AMP. Increased levels of cyclic AMP are responsible for producing that bronchial smooth muscle relaxation. Also, the formation and release of inflammatory mediators from mast cells are inhibited by increased levels of CAMP or cyclic AMP. So if we inhibit the formation of mast cells, we've inhibited that allergic response, or that response that will cause bronchoconstriction. So consequently, in asthma and COPD, the aim of therapy is to administer sympathomimetic drugs that stimulate beta-2 adrenergic receptors, or anticholinergic drugs that decrease parasympathetic activity. So bronchodilators, or beta-adrenergic drugs, these are sympathomimetics. They stimulate beta-2 receptors in the lungs, which leads to bronchodilation. So those the bronchodilating effects of these drugs begin almost immediately after inhalation, and they are considered rescue drugs, meaning you use them in the middle of an attack. Our longer-acting beta-2 adrenergic drugs are salmeterol and formoterol, and those are usually used more for control because they have long-term action and can be used to prevent an asthma attack. The selective beta-2 drugs are usually well tolerated since they are administered by inhalation and not usually systemically absorbed. Side effects include nervousness, skeletal tremors, skeletal muscle tremors, increased heart rate, especially with oral administration. Those are pretty much the most common side effects. So bronchodilators, other than those, include methylxanthine drugs, and their mechanism of action is to inhibit phosphodiesterase, which leads to an increase in cyclic AMP, and again, a decrease in mast cell formation. So the physiologic effect is direct relaxation of the respiratory tract and bronchodilation, usually used for chronic bronchitis and COPD. Side effects include nausea, vomiting, flushing, vasodilation, and hypotension. Theophylline is the only natural methylxanthine used for its bronchodilating agents. So, anticholinergics, and here we are again inhibiting the parasympathetic system. So by blocking the actions of acetylcholine, anticholinergic drugs produce bronchodilation and also reduce the volume of respiratory secretions. They're not as potent as our beta-adrenergic drugs and are primarily indicated when other bronchodilators are contraindicated or if additional bronchodilation is needed. In COPD and especially chronic bronchitis, there appears to be increased cholinergic activity. So usually our bronchodilators that are anticholinergics are used a lot in COPD. So they're considered first-line drugs. Some bronchodilators that are anticholinergics include ipratropium and tiotropium. That first one starts with an I, and it is a shorter acting. The second one is a longer acting, again, most likely used for control. Side effects include excessive drying of the mouth and upper respiratory symptoms, and they're usually, again, used in asthma or COPD. On slide 17, there's a long list of our bronchodilators there, as well as how they might be administered and how long they last, and their indication. So, anti-inflammatory drugs, corticosteroids. Their mechanism of action is they interfere with all stages of the inflammatory and allergic response. They have potent anti-inflammatory actions. Corticosteroids inhibit the activity of inflammatory cells, the release of inflammatory mediators from mast cells, the production of allergic antibodies, edema, and many other anti-inflammatory actions. One of the main uses of these drugs is for the treatment of inflammatory and allergic conditions such as asthma, and the major effect is, again, to cut down on the swelling that might be going on in the airway. Adverse effects usually include oral infections, hoarseness, and vocal cord disturbances. And these are usually used as controller medications to prevent an attack. We always tell patients to wash their mouth out afterwards, rinse their mouth out with water, so that corticosteroid isn't hanging around in their mouth causing the fungal infection. And that pretty much covers corticosteroids. There's listed on slide 19. You might hear some, go to the slide. Some of them might sound familiar to you, such as fluticasone or Flovent, as well as Advair, which is a combination product between a corticosteroid and a long-term beta-adrenergic. Pulmicort or budesonide is pretty commonly prescribed. So again, good slide to look over, but again, try try to familiarize yourself with the names and not so much the doses or the other information. Okay, so moving on to slide 20, anti-inflammatory drugs continued. Leukotriene inhibitor drugs. Earlier we talked about leukotrienes being chemical mediators that were pretty potent. So if we inhibit them or prevent their synthesis, we can control chronic asthma. So adverse effects of these medications include nausea, diarrhea, rash, and headache, as well as increased liver enzymes. So we do have to have some baseline liver function as well as some follow-up tests. Usually this would show up to the patient as fever, dark urine, clay-colored stools, or jaundice, and that would be reported to the physician, and they may possibly be taken off of the medication. Our leukotriene inhibitor drugs include Accolate and Singulair are the brand names. Zephyr-Lucast and Montelukast are the generic names. A little bit newer on the market, not as commonly used, say, as the inhalers. Again, we talk about cromolyn sodium, just like we did in chapter 31. It needs to be given before the asthma attack, taken prophylactically before exposure to a trigger. And if you have any questions about how it acts, you can refer to chapter 31. Adverse effects, again, nasal stinging, irritation, headache, bad taste, and allergic reaction. Random anti-allergic agent includes Xolair or omalizumab. It binds to and inactivates IgE, and thus it reduces the severity and frequency of asthma attacks. It's an injectable, so the biggest side effect we see is pain and inflammatory reaction at the site of injection. Mucolytics and expectorants. Some of you might be pretty familiar with Mucinex. It's an expectorant. It breaks up the mucus and facilitates the removal of it from the lungs. The generic name of Mucinex is guaifenesin. Mucolytics liquefy bronchial mucus and enable mucus to be removed by coughing or suction apparatus, and that includes acetylcysteine. This is usually used in a patient maybe with cystic fibrosis who has really thick lung secretions. And it can be given a couple of different ways, most likely by inhalation. So preferred therapy on the final slide there. Mild to intermittent asthma or COPD, usually a beta-2 bronchodilator. Mild persistent, corticosteroid, cromolyn, or an anti-leukotriene. Moderate persistent, corticosteroid, beta-2 bronchodilator. And severe, we're going to throw a few things at it. Corticosteroid, beta-2 bronchodilator, and an anti-leukotriene. So that covers chapter 32.